So, good morning everybody. I assume that you are a little bit maybe tired, and I will start to introduce myself, where I work and where I live. So this is a part of the university hospital from Düsseldorf, and this is a very brand new building, and the children's department is, or the children's hospital is located close by. The children's hemato-oncology department is one of the biggest in Düsseldorf, and at the university hospital I run the comprehensive care center for Fanconi patients. We are in the very lucky positions that I organized with the head of our department to see also adult Fanconi patients. So we see all our children and we keep them, so we do not send them to the adult people when they are grown up or when they are elder than 18. Normally you have to do this, but we have like a special arrangement with the insurance companies and with our hospital that allows us to do so. I'm very proud that we have found throughout the years many people that are very dedicated to Fanconi anemia, and I'm very happy that we have a specialized pediatric radiologist. So when I have like the question of what type of screening I should do, is it okay to do an X-ray, should I need really a CT scan, or is it possible to do an MRI or an ultrasound technique? He is very aware of the special situation of Fanconi patients, so it is good to have a team together. So even though I'm standing here on my own now, there's a huge team in my back from very dedicated colleagues. I see Fanconi patients on a regular basis, and I'm also on the telephone for advices for my colleagues in Switzerland and in Austria. And it's very interesting. Some of these patients, especially the adult ones, they come once a year to us to Düsseldorf. We do the bigger checkups and then they go home with our recommendation. And this system works quite well, so I'm very happy that I also can share some of the experiences of the use of androgens, especially also for the long-term follow-ups. This wouldn't be possible if I would not see the adult Fanconi patients as well. Despite the fact that I really love my clinic, Düsseldorf is a very famous city and a very nice city as well. And this year it is one of the cities that is in the top 10, so it's on the position 7 of high quality of living. So if you want to come to Düsseldorf, you are really invited. It's a very nice city. We have a mixture of city style and it's a more like village style, and we serve good chocolate, we serve very good beer. So, okay, now I want to challenge you. I want to use the next 5 minutes to maybe put you in my position, for me as a pediatrician, for me as a clinician. So, I would like to think about what type of medicine are we doing. And I would like to summarize a little bit of the things that people have done before now, our days. So Hippocrates was one of the first physicians or scientists that tried to study how is the human being set together. And he was a big fan of the Humoralism, and this is a concept of the 4 humors, and the yellow bile, the blood, the phlegm, and the black bile. And you can see this is a citation of Hippocrates, and he stated that the human body contains these 4 elements of blood, phlegm, yellow bile, and black bile, and these are the things that make up its constitution and cause it pains and health. Health is primarily the state in which these constituents, substances, are in a correct proportion to each other, both in strength and quantity, and are well mixed. Pain occurs when one of the substances presents either a deficiency or an excess, or is separated in the body and not mixed with others. Yes. When I heard this the first time, I exactly reacted the same way. I said, what a pure bullshit. But this is how they made medicine, and they treated patients for more than 2,000 years. They really thought this is how diseases occur, this is how diseases arises, and these are the ways how they should treat patients as well. So when you had like too much blood and it causes some of the problems, they had to put more black bile in the patient or reduce blood. So it was like some of the patients died due to this treatment, some of the patients did well. But it lasts for more than 2,000 years, that this concept of medicine or of diseases was a standard, the standard concept. Luckily, time moved on, and we can name it with a special date when Robert Koch looked through his microscope, and it was the beginning of the golden age of microbiology. And he founded the tubercle bacillus, so Mycoplasma tuberculosis, which causes tuberculosis. And this was amazingly, when you go to the literature at that time, it's fantastic to read this, because you can see now time changes, now we have the reason for everything, now we have the explanation for everything. There was a bacterium for obesity, there was a bacterium that causes depression, so it was like the new wave of explaining how diseases arises, and it was all about bacteria. It's interesting when you think about it, was discovered in 1882. It took nearly 40 years until this pure knowledge about the existence of bacteria turned into a type of treatment. First of all in the animal, and then 20 years later the first vaccination was used in men. So think about this. So knowledge is very important, but that we are able to use this knowledge as well as a therapeutical option, unluckily takes some time. So time moved on, and we came to the very famous molecular transition of medicine, and I'm so proud to be part of it. I'm very happy to be part of it. So you see Watson and Crick discovering the DNA helicase, and this is a picture 50 years later. I like this, to see the two old guys standing there as proud as 50 years before. Now we know everything. We know that bacteria are not causing all the problems. Now we know that all the genes that are in our body cause everything. But let's think about this. So this is type of what we think about how diseases arises, how diseases occur, and also what type of treatment we have to do. I'm very happy that we will hear tomorrow talk about gene therapy, but still, you know, thinking about that we know about the genes is a long time ago, and that we still have no real causing therapy option or therapeutical option about using this knowledge. It's how medicine is working. So I have 3 of the disease models. Maybe you can have in mind, maybe, so this was not right at all, this was a type of right, and this as well. But we cannot explain everything. And why do I share this information with you? I want you to have the feeling when I have a patient in front of me, I would like and love to know everything. I would really like to understand the whole disease, because when I understand, I can choose the right treatment option. And I, for sure, only want to take the right decision. But in our days, it's like we always have to balance things. We have to discuss, and we have to find out what are the right treatment options. And I really have to say, I'm very, very, very glad and thankful to all the support groups throughout the world, especially to FAF and to the German Fanconi support group. Me as a physician, this helps a lot to discuss my ideas with the parents and to find the right way to take action. It's not about that we as a physician take action and that you have no way of arguing or thinking about. And this is something what I like to give you as information before I start to the heavy stuff now, because it's very important. I would like to empower you. Sometimes we do not know exactly what to do as a physician. Some situations we know for sure, and there's no discussion at all. But when we talk about blood counts in Fanconi patients, you should know what is the problem, what is the situation, and you as parents, have the same opportunity to take decisions like we as physicians. So this is the starting point, and now we go into the depth. So when we discuss about the use of androgens, we discuss mainly about bone marrow failure. So bone marrow failure is the main cause of morbidity and mortality in Fanconi patients, especially in the first decade of life. And it ultimately leads to transfusion dependency and to pancytopenia. That means that the body and the bone marrow is completely empty. We really like to scale things, so this is from the handbook, everyone can read this. So we have 3 situations of bone marrow failure, and this is very important now for the rest of my talk. So I would like to go through this, even though I know that Dr. Alter for sure mentioned this in her 101 slide and lecture. So we have mild bone marrow failure, we have moderate bone marrow failure, and we have severe bone marrow failure. And here you can see the definition. It's about the ANC, the absolute neutrophil count, the platelet count, and the hemoglobin level. So these are the 3 definitions, and you have to keep this in mind when we now continue our discussion about the use of androgens. This is also a graph from the new guideline book, and I would like to point out there are 2 situations where we really do not have to discuss treatment options. And this is the normal marrow or the mild marrow failure and the MDS or the AML. So when you have a child and your child shows MDS, and it have to be done so MDS has to be diagnosed in a lab that is very familiar with Fanconi anemia. Do not go to a standard lab, because when you look into the bone marrow of a Fanconi patient, you will find signs for dysplasia even when you have only mild marrow failure. So the one that is examining the bone marrow should be very, very, very knowledgeable about Fanconi anemia. So when you have MDS or AML, there is no discussion at all. You have to go to BMT. Either there are different options, what type of BMT we should do, but these are the next talks. I do not want to step into this now. And also when you have the normal bone marrow or the mild marrow failure, it's watch and wait situation. You do not, for the time being, you do not need a treatment. Maybe we are on our way to have new therapeutical options like the quercetin. Maybe these are things that can jump in this position already. So when we talk now about the use of androgens, we talk about the moderate marrow failure and the severe marrow failure. And in these 2 situations, you have the 2 decisions about using androgens or going for BMT. And because we have now in the later talks the discussions about BMT, I would like to highlight some of the risks, advantages, and beneficial things about the use of androgens. So when we talk about androgens, we have a very, very long use of androgens in Fanconi anemia. So Shahidi published a second paper in 1961 about 24 cases where he treated Fanconi patients and acquired aplastic anemia patients with testosterone. And it's a very interesting paper to read, because he was very dedicated to write down all the side effects, all the effects, and it was really the beginning of the use of androgens in Fanconi patients. But since then, when you look to the literature, you only have very, very, very little publication. You find very little publication about the use of androgens. So that makes us, as clinicians, also very difficult to find out now what are the advantages and disadvantages. And there are anecdotal experiences and expert opinions. We call this not evidence-based medicine, but eminence-based medicine. So that talk about that only or approximately 50% of all the Fanconi patients that received androgens may respond, and some of them more transient, and only very rare patients have long-term response. So this is what you can find out when you ask your colleagues about the use of androgens in Fanconi patients. And I would like to put on to work on these 2 sentences, because I do not think that these 2 things are right. And I would like to share some of the information and some of the results that we have throughout the world with you. So when we talk about androgens, we of course have to talk about the mechanism of action. And normally I should write a very big question mark in this slide. Think about this. We use a type of medicine for more than 50 years now, and we have no clue at all how these type of drugs work. Isn't this amazing? For me, when I finished medical school, this was the reason to jump into the clinical care of Fanconi patients, because I saw a 16-year-old girl shaving at the morning in the youth hostel at the family meeting because she was taking high dose of androgens. And I thought, this is not a treatment option that I would like to do as a physician. And this was for me the point where I said I will jump from basic research more to clinical work. So we are in the lucky position that we maybe have an idea how androgens work. And this is work done by Markus Krompe from Portland. And they studied oxymetholone use in Fanconi mice. And they found two things in these mice. So they have found that the stem cells and the progenitor cells are stimulated to proliferate more frequent, which ultimately, unfortunately, led to an exhaustion of stem cell pool in these mice and to a down-regulation of osteopontin. To tell you the truth, I never heard this osteopontin beforehand, so neither did the other hemato-oncologic physicians from me did. So this is a very interesting protein because it has many, many functions. It is involved in T-cell activation. It also controls apoptosis. So normally it downregulates, it is an anti-apoptotic protein. So maybe that the oxymetholone has also something to do on the osteopontin, leads the cells more to have the potential of to proliferate than normally and not to die. So these mice finally had because of a huge the stimulation of the proliferation, they got to an exhaustion of their stem cell pool. And this is something what we would not like to see in our Fanconi patients. And I'm not so very convinced if this is also the type of mechanism in our Fanconi patients, because this is something that I do not observe. Some of the Fanconi patients that I treat with androgens are more than 15 years on the androgens, and I do not see any exhaustion of the stem cell pool. When we check the bone marrow, the cellularity is the same and the blood counts are stable. So when you go to the publication, you see that oxymetholone also has its impact on the control group. So the non-Fanconi mice had also increase of blood counts and also an exhaustion of their stem cell pool. So it might be not the perfect model to study, but maybe. But finally, we really have the first step. So this is to bear in mind. The researchers are on their way, maybe to understand how androgens work. So this is a good thing. What are the big advantages of androgens? So, and the first sentence is something that I really must say, like as a physician. It's absolutely absent of a short-term and a very low long-term risk of therapy-related mortality. You have to think about this. Because the other option of using androgens, when you do not use androgens, you have to go to BMT. The transplant people made huge progresses in the BMT, and I'm very happy to live now and not 30 years ago, because nowadays the results and the outcome of a BMT are so much better than 20 years or 30 years ago. But still, it's not a therapy that you would say has low risk. It's still a very high risk therapy. And when you compare this to the advantages of using androgens, you really can say you will not kill a Fanconi patient with the use of androgens right away. For sure not. And when you have him in good hands, or the patient in good hands, you can also check for the risks, and you can reduce the long-term risk of therapy-related mortality. Another beneficial thing is that we have a very long history of experience in the use of androgens. So as I said, the first publication was in the early 60s, so it's more than 50 years of experiences. And it's not an experience that lies only in the hands of the physicians, but it's also in the hands of the families. So I learned a lot of androgens from the families themselves. And what is also an advantage, the side effects have been very well documented and are absolutely related to the absolute dose of androgens given per kilogram of body weight. It's very interesting because normally you would say that some of the side effects are also related to a cumulative dose. That means when you are a long time on androgens on a low dose, this is the same, or you show the same side effects than when you have a short time, a high dose. But this is not true for androgens. So when you want to reduce the side effects, you better should use a low dose, because when you have a high dose per kilogram of body weight, you can expect the side effects. So what are these side effects? Normally they are very well known. It's virilization, including acne, and the acne is for sure the thing that we see in all of the different type of androgens. Then we have facial hair growth, we have scalp hair loss I never saw, a deepening of voice, development of pubic hair, enlargement of penis and clitoris. And I must say that these effects you see, also the second point, the growth spurt, but what finally leads to premature closure of the epiphysis and then later on an exacerbation of the short adult stages. These things really seem to correlate a little bit to the age when you start to use the androgens. So when you start in a 10-year-old, you have more male side effects than when you are shortening of the adult stature than when you start when the patient is 20 years of age, for sure. Sometimes, depending on the type of androgen that you use, you see hyperactivity and behavioral changes. And this is something what we really have to bear in mind. It's not something that we have to ignore. Then we have effect on the liver. And this is a point that I would like to point out. We see hepatic adenoma and hepatocellular carcinoma in the literature, very frequent. I also see hepatic adenoma in the use of oxymetholone, very frequent. I never saw it when I use Danazol, and this might be because it is activated in a different way than the oxymetholone. And about the hepatocellular carcinoma, I'm not so very sure. When we go to the literature and we search those cases are 30 years ago published, and this is a time where maybe we had not such a good treatment option. The patients have been heavily transfused. Most of them have a high iron overload, and this might be an additional factor of what we do not have in our days. In our days, we start earlier with the use of androgens, at least in Germany. Before the patient get heavily transfused, we try to reduce the amount of iron that the patient has in his body. We measure the liver iron routinely with MRI techniques to find out, because we know that iron is not beneficial for the liver. And I mean, I cannot prove it, but I think in the last 15 years, we do not see any hepatocellular carcinoma in Germany, and I'm not so very sure about whole Europe. But this is something to bear in mind. So I would say the hepatic adenoma is really something what we have to think about, but about the carcinoma, I'm not so very sure. Pileosis hepatis is something what we really have to avoid. I never heard this term before I stepped into the Fanconi group. And pileosis hepatis is, these are small vessels that start to grow, and they are filled with blood, and then they kill liver cells around. And when you see when you do an MRI and you see the liver of those patients, it's like when you have a black picture with many white spots, and this is dangerous. When you see something like this, you really have to stop immediately or reduce the dose because they can rupture, they can bleed, and when you have liver bleeding, then this can be lethal. And another thing that we have to bear in mind is hypertension. I will show you this in the following slide. This is one of my patients that I treated with oxymetholone, and I treated him because the family decided to use oxymetholone because he was a boy. And every one of us knows the white coat effect. The white coat effect is when you go to the physician and the physician takes your blood pressure, and the blood pressure will be high because you are nervous. So when you really want to see if when you really want to scale if his hypertension and when you use a patient with androgens, you have to have a 24-hour blood pressure measurement. Otherwise, you cannot really figure out if there is hypertension present or not. So in this patient, you see there are some peaks that are absolutely not nice. We do not want to see blood pressure in a child that this is that high. And even during the night, he had not very low blood pressure, so he was also high in blood pressure during the night. So we started him on a low dose of medicine, and he responded right away. So this was very beneficial. But you can easily miss this when you do not check very carefully. So this is another slide I show you. This is you see the kidney malformation. This is the stomach filled with something tasteful, and there is a huge adenoma in this boy treated with oxymetholone. And the striking fact was that we were checking his liver enzymes, we checked his AFP, and these numbers do not correlate at all to the development of adenoma. So his liver counts were like a little bit fluctuating. The AFP was the same like last year, and when the radiologist called me because he was seeing him in the ultrasound and said, you know, I found this adenoma. I was really shocked because it's a huge one. It was 5 centimeters in diameter, and when I only would have looked on the blood results, I would have missed it. So when you have a patient on androgens, it's not enough to only do the blood work, but you also have to do ultrasound and MRI techniques. And I would assume that you do this at least every 6 months. So the good thing is we stopped androgen treatment in this boy. He had a perfect match. He was transplanted and he's doing very well now, 4 years after transplant, and the adenoma is completely gone. So nowadays, it's also something that I would like to say. The use of androgen has not anymore any disadvantage before when you go to transplant. So this is something what you have to bear in mind. 20 years, 10 years ago, this was the fact, but the analysis of the new data does not show this. And even though I do not, in Düsseldorf, we do not have many Fanconi patients transplanted, this is something what Wolfram Ebel from Berlin also says, and maybe Perinda Mehta from Cincinnati will focus on or mention this in her talk as well. So what are the risks? And this is something that we also have to think about, and this is why I introduced you about when we have to take decisions, we also have to think about risks. These are not side effects, but these are risks. So with the use of androgens, it does not prevent the development of AML. So when you have a bone marrow transplant and it works and everything is fine, you have a very, very low risk of AML. You eliminate the elevated risk of AML in Fanconi patients. This you for sure would not do with the use of androgens. And if they work and the patients get older, but maybe there comes a point when MDS develops or you have side effects and then you have to go to BMT, then the patients are older. And age is still something what has an impact on BMT. So this is something what we have to focus on for the future, what we do not have to say as when we have to take the decision to put someone on androgens, yes or not. This is something what we have to bear in mind. So now I would summarize what types of drug do we use. So this is testosterone. We do not use anymore we use oxymetholone or Danazol. In the States, we have also oxandrolone that we do not use this in Europe, and Nilevar was also used in the past years. Nowadays, I treat patients more frequent with Danazol. I only very rarely use oxymetholone. We also have to say that it was sometimes very difficult to get the oxymetholone because it is produced in Turkey, then it's produced in Iran, and then it's produced in other states. So, but because it's not a typical drug that is on the market, it's sometimes very difficult to get it. And with the Danazol, I never had problems to get the drug. So this is also a big advantage of Danazol. So I would like to summarize data from Brazil, and these are amazing data about oxymetholone. So these following slides are from our colleague Lisandro Ribeiro from Curitiba. He is a co-worker of Carmen Bonfim. Carmen Bonfim transplanted more than 250 Fanconi patients, all by herself. And they really take the decision either do we do a transplant or do we use androgens. And they put together 49 patients and analyzed them retrospectively how they responded on oxymetholone. And as you can see, they used a very, very low starting dose. Normally, you would start like with 2 milligram per kilogram, and then the old handbook, it was also recommended to raise the dose up to 5 milligram per kilogram. So they really use a very low dose of oxymetholone. And they have very hard criteria of what they called hematological response. They wanted to see an increase in the hemoglobin about 2 points above base level, or 8 weeks of transfusion-free period, and the platelet counts 2 times above the baseline, with an absolute count over more than 30,000, and an increase of the ANC also 2 times above the baseline count, and for sure about 750. And what they have seen, even with a very, very low dose, they have a response in 40 patients, which is 83%. And this is a very, very, very good number. And I'm very happy that they presented these results at the last FARF meeting. And it's very interesting because they see these response with a median in the first 3 months. And this is a very, very short time of working. So now we have like some of the graphs, and you see these are the 49 patients that they treated with, and you see it's a 3 months interval, and they have a very nice and very stable response. And when they once saw a response, they tapered down the dosage of oxymetholone to what they needed. And it's the same for the platelets, and when you see they started with the median at 20,000 and end up around the 60,000, this makes for the patients a huge difference. And also about the ANC, so the ANC is something when you go to the literature and you check for androgens, is something what is not very, very reported. So this is the first analysis of the impact of androgens on the ANC, and you really can see that it also has its impact on the ANC, not only on the platelets or the hemoglobin, even though the hemoglobin is, of course, the thing that you see the first. Toxicity, they have to state that all the patients develop their variable degree of virilization, and it's, of course, more evident in girls. So the female patients have had a deepening of voice, and this was not something what you can ignore. So 2 of the girls suffered from bullying at school, and this is something what we do not want for our patients and for our children that have so many problems at all. So so it's we have to bear this in mind as well. And he also saw what I already mentioned before, when the patient have been older at age, when they started, they saw less viralization. Liver toxicity with elevating of the liver enzymes, they saw also quite frequently, and in 6 patients, they stopped treatment until they reached normal value, and then they restarted with a lower dose. And 1 patient developed this pileosis hepatis, but this was a patient that did not respond to oxymetholone, and then he needed a very high dosage. So it's really something what is also correlated to the absolute doses of oxymetholone. Now I would like to share some in the last few minutes experience of Danazol, and I think this is a drug for the future to go with. I really can say so, because I'm absolutely convinced that it's a very safe drug. And this is Dr. Sue McIntosh, and it was a very nice experience for Ralph and me to meet her in person, because she was one of the first physicians in the States starting to use Fanconi patients with Danazol. And it was interesting to share her experience, and she was a little bit like, yeah, you know, I had no other option, so I chose Danazol, because I knew this from my other colleagues that treated aplastic anemia, that they use the Danazol more frequent than the Oxymetholone, so I thought about why not using it in Fanconi patients as well. So it was very interesting that she had no clue at all that she did a very, very important work there in Yale. So now I would like to show you a graph from 4 different Fanconi patients. And I choose these 4 Fanconi patients out of the huge box of Fanconi patients that I see with Danazol because of different purposes. So this is a patient that most of you know, and it's a patient that started at the age of 13 with a Danazol dosage of 3 milligram per kilogram. And now the next slides will be all the same. So in the first, you see the first year a little bit more elevated, and then the following years a little bit more taken together. So in this patient we had low counts in all 3 lineages. The Danazol was started. We haven't seen a good response in the platelets and the leukocytes and the neutrophils, but effect in the hemoglobin, so dosage was increased. And then it took some time, but then you saw a response in all 3 lineages. And this led to the tapering of the dosage to a very, very, very low dosage, about only 0.5 milligram per kilogram. And you still see that you see an elevating in this in the counts, and then later on a little bit of decrease. So this is something what you have to bear in mind when you treat patients with Danazol or androgens per se. You see the effect of the change of dosage not immediately. You have to bear in mind, and you have to think about that the effect maybe you see 3-6 months later. So when you taper the dosage down, you have to be very careful in follow-up, and if you increase the dosage, you should not expect the change in the counts within the next 2 weeks. This is another patient, and I would like to show you this graph because this was very interesting for me. So we tapered the dosage very, very, very in small intervals, but you see still an increase in all 3 lineages, also in the neutrophils. And this patient had 200 neutrophils when she started, and she is now at about 700 neutrophils. So she's doing very perfect, also with a very low dose. And this is a patient where we had the idea and the discussion about should we start androgen or not, because she already had a high hemoglobin, about above 12. But the other counts have not been good, so especially the platelets. So we started with a standard starting dose of 5 milligram per kilogram. You see an immediately response in the hemoglobin. We saw a first increase after 4 months in all 3 lineages, which finally stabilized a little bit. So we are happy that we saw a response in these lineages, not only in the hemoglobin. And now I would show you one of my patients that caused me a lot of stomach pain. And it is not a funny story, because this patient had very, very, very low counts, and she was not doing fine at all. But the patient neglected to go for BMT, even though she had a perfect match. She was 22 years of age, but she lost her sister during the BMT. And for her, it was no discussion at all to go for BMT. So I said, okay, then let's start Danazol. And as you can see, in the beginning, we had no effect at all. It was, for me, a very hard situation as a physician to see my patient suffering from the loss of her sister and the bad health status that she had. So I increased the dosage up to 10 milligram per kilogram weight, and I never used that high dosage in any Fanconi patient before. So I was not aware of the side effects that I will see. So I had her in a very frequent and very short-term interval of follow-up. But then finally she responded. So, and when she was doing stable for 2 years, I decided to decrease the dosage because I was afraid of having her on that high dosage for such a long time, even though I have not seen any side effects in the liver enzymes and in the ultrasound. And we decreased the dosage, and let's see what started. So she is doing perfectly now. She has a hemoglobin around 15. She had platelets about 100. And she's very stable with all her other counts, and she's now at a very low dosage of Danazol. So there might be a lowness in, or the decrease of counts in the next time because we had to lower the dosage so much. But I would like to show you a picture of this young girl to talk about side effects. So this is she, and she's an actor, she's a model. And she is very, very happy with her life now. And she loves to have double roles in movies. She plays always children. It's a very interesting thing. She has really, she's very dedicated. She had movies that have been shown in the cinema, and I'm always so proud when I see her name at the end of the movie. And yeah, I'm happy that we have Danazol because she wouldn't be alive and able to work in her position as she did now. But we have to have in mind she was 22 when I started the treatment. So viralization effects is something like this. Last slide. When we talk about time and androgens, it's something what we have to think about. When we speak about age in Fanconi patient, we know that the risk of developing solid tumors, squamous cell carcinoma, increases in time. But this is not something what we can see in the literature for AML. So maybe this is something what you think about when you use androgens. Time matters, of course, but from my point of view, androgens are absolutely an option in parallel to BMT, and it's not a decision that only the physician alone takes, but that you as parent and a patient as well take together with your physician. So I would like to finish with this statement.
Thank you very much.